So hello, everybody. My name is Dr. Elizabeth Leroux, and I'm a neurologist. I practice here in Montreal, Quebec, and it is my great pleasure and honor to be here for this webinar about myths and facts about diagnosis. This is a special week. It's June, the month of migraine awareness, and I'm very glad for you to be here. I would like to thank our sponsors at Migraine Canada, and our work would not be possible without them. You can see the list. It's a growing list. If anybody has a contact, we are now charitable. If anybody knows anybody who would like to donate or support Migraine Canada, a company, a corporation, please do not hesitate to get in touch with us, and we'll get the ball rolling. This is a special day. This is actually a day for illuminations. So our team has successfully arranged the illumination of different places and different monuments in Canada, across Canada, in Toronto, Niagara Falls. Beautiful falls will be illuminated in purple. Purple is the color for migraine awareness. Vancouver, Calgary, and my Charlottetown, and Montreal, my hometown. So if you're close to one of these places, take a pic and share it on our social media. The other thing that we should be doing is Shades for Migraine. This is a very nice initiative from a group in the US, and they have this campaign called Show You Care, Wear a Pair. So all you have to do is take your coolest set of sunglasses, and a lot of people with migraine have sunglasses. Put them on and take a pic and share it on social media with hashtag Shades for Migraine to raise awareness. Before we start, I am a neurologist and I am a headache specialist, but I am not your neurologist and I'm not your healthcare providers. Migraine Canada provides information, not medical advice. So the discussion and information I'm going to present tonight might not apply to you. So whatever I'm saying first, I don't want to go against your healthcare provider. My hope is that you learn stuff that might raise questions or maybe clarify things that have been told to you already. And then you can go back to your healthcare provider and discuss and clarify what your diagnosis is. So let's get started. So tonight is about myths and facts about migraine diagnosis. And in med school, we used to say, you know, there are horses, common things, and there's zebras that are rare. And then you even have this thing here in the middle, which is a zorse, a mix between a horse and a zebra, because sometimes headache diagnosis is complicated. So once I was actually preparing a talk for doctors and specialists, and I just, by complete serendipity on the big web, I found this website by Dr. Smith. This is a real website. You can have a look at it. And I found it was interesting because as a neurologist and headache specialist, this made me cringe because those diagnoses are not correct diagnoses, but these are seen on social media and I see a lot of them. I think the reason why it's because people very naturally will link the word migraine with a lot of other things. And for example, here we have aura migraines, chronic migraines, ocular migraines, post-traumatic migraines. Interestingly, we try to use migraine singular as a disease now. And migraines, plural, we try to steer away from that. But you know, just feel comfortable using what you prefer, but usually we try to stay with the singular. So tonight we'll go over Dr. Smith's list and see, you know, if we can clarify some of these terms. And like I said, some of them are correct. For example, hemiplegic migraine does exist, but others are very misleading. Well, let's start by just a definition about words. Tonight is a lot about words, correct words, what words we should use. The difference between a disease and a syndrome. So the whole story of medicine is about putting symptoms together, right? Symptoms are what people feel and perceive, and signs are what we doctors or any healthcare provider will examine, and they will objectivize this. They will see this on clinical exam. So we put a bucket or a group of symptoms and signs together. And it's like, well, this looks like it happens in the same person, looks like something that happens. And then we try to understand what is going on with imaging, blood tests, electrophysiology, and so on. So if we can pair an ensemble of symptoms and signs with something that we can objectivize and that just tells us what the cause is, so biological evidence, objective evidence, tests, then yes, we're talking about a disease. No, then we may be talking about a syndrome, which is a set of symptoms and maybe signs that are not yet explained and for which we do not have yet tests, right? So I'll give you a few examples. So some health issues are super easy to see, right? So here you have a CT of the lung. It's a lung cancer. There's a big mass there, and it's pretty obvious. On the other side, you have a bone fracture. So let's say this person fell off a bike. The bone is visibly broken. Doesn't take a diploma in medicine to see this, and you can confidently diagnose a bone fracture. But then in the history of science, what we could see with the naked eye was not enough, right? There were things that we could not understand. So then we started looking with better tools. An example was the EEG, electroencephalogram, because in the old days, epilepsy, right, seizures were thought to be demonic possessions, right? So people thought that some kind of spirit, because you couldn't see anything, right? So people thought that it was all about a spirit taking hold of you. It's what is called a seizure, actually. It's because you're being seized by some external thing. Now with EEG, we know what epilepsy is, and we've come to understand it. On the other side, we have the examples of infection, something we've talked a lot about in the recent years. Remember that in the old days, we could not see viruses and bacteria and prions. So it was just like some things in the air. It wasn't possible to see them and to treat them. So something like tuberculosis, for example, that we know very well now, we couldn't see before later in the 1900s. So we have examples of bacteria, and thanks to the microscope now, we can see bacteria and viruses and prions and understand them. Other diseases we can measure easily as well and reliably. So for example, the thyroid disorder, well, you can do a TSH, right? You can just take a blood test and then the doctor says, oh, your TSH is high, your TSH is low, because the symptoms of thyroid disorders are not super typical. They are actually very common symptoms, fatigue, weight gain, right? Very unspecific. On the other side, we have another disease, hypertension, which has no symptoms most of the time. The problem is when it leads to a stroke or heart disease. So we know now that we should keep blood pressure low. And luckily for us, we can measure blood pressure very easily. So you can see just a whole array of symptoms and how disease is diagnosed. So can we measure migraine? Can we see its cause? That's the question. So here are the official diagnostic criteria of the International Classification of Headache Disorders. I'm sorry, this is a bit dry. This is kind of medical lingo, but I think it's important that you guys understand why we have a classification of criteria. It's because since we didn't have any evidence for the cause of these things, well, we needed to have at least a fair definition and description of what we were talking about. So experts sat together in the 90s and said, okay, this we're going to call migraine based on observations of the previous centuries, right? And then criteria were formed and it was an agreement. So in science, we need rules to say, okay, this is what we're talking about. Let's look at it and let's try to see if we can make some sense and find some causes for this set of symptoms. So the key symptoms for migraine, as I'm sure you have experienced, are attacks of head pain with other symptoms, nausea, sometimes vomiting, sensory hypersensitivity. This is an old drawing from the 18th century. And this lady here is holding her head. She probably will go to the bed because her supporting lady here is, or maybe the nanny is preparing the bed. The other nanny is taking care of the kid, saying that maybe now is not a time to play the drums. And the boyfriend here is said, maybe I was going to do a little show, but I'm going to forget about that because obviously I need to be very quiet now. And she even has a butler who is kind of hiding the fire because she has sensitivity to light. In the modern days, a lot of us ladies do not have two nannies and one butler to take care of us. But still, we do live with migraine, and the men as well. We live with migraine, and we have to deal with it. So up to this day, migraine does not have a biomarker that we can use in practice. So when we talk about a diagnosis, we cannot measure migraine with a blood test or imaging that we doctors can prescribe reliably, right? So if you had a big brain tumor, it would be very visible on an MRI or CT scan. It's like if you take a laptop and it's completely visibly destroyed, this is very obvious. Migraine is seen on other techniques. So for example, if you do an MRI of the brain with migraine, it will seem normal in appearance, but it's not normal. How do we know that migraine is not just a syndrome and a set of symptoms? How can we say that migraine is different, that there is a cause, there is a biological cause for migraine? In the 70s, people thought that migraine was a psychosomatic disease, that it was all a matter of emotions, and that maybe it was even imaginary. But now, thanks to different techniques, gene analysis, microscopes, fMRI, which is functional MRI, chemistry analysis, we know more. So we can actually now see migraine in research. And we can actually have models, human models. This is a model from the Denmark Center, where we can inject substances to someone with migraine and see if it triggers attacks. And so we understand that those substances can actually be targets for treatment. You might be wondering now, what is she doing, Dr. Leroux? Because she told us she was going to talk about diagnosis. But it's very important to understand that diagnosis is linking symptoms with a cause and with what we call pathophysiology. So that's why I'm showing you this. That's another evidence on the right side, a functional MRI study done in Germany showing the zones of the brain that are active during migraine. My point is, we know the causes, some of the causes of migraine now. What we know is that it's something genetic, that there are some chemistry things, some electricity things. For example, people with migraine have a low serotonin. They have also difficulty habituating to stimuli. And all of this leads to the symptoms that people have. I won't go into detail here. This is the slide, the more advanced slides that I do show healthcare providers and neurologists when I teach. This is all the pieces of the puzzles, the migraine puzzles that we know up to this day. Okay, so this, and if you want to dig just for fun, let's dig a bit deeper. This is a sensory neuron. This is a cell that we all have in our bodies that takes care of carrying sensory information and pain. Those are all things that we know about, little proteins and so on that we can study. So you can see the degree of complexity that we have reached in understanding migraine. This is another thing I'm going to skip very, very quickly on, but this is actually a diagram just explaining the metabolic aspect of migraine. I show you this just to tell you that we have understanding of some of these things that causes migraine. All right, let's go back to Dr. Smith. Now that we have said that migraine is a disease and not only a syndrome, though it is still difficult to measure. So Dr. Smith here treats things like cluster migraines, hypertension migraine, tension migraines, and post-traumatic migraines. So this is actually not a good way to make a diagnosis. Let's go back to our international classification. Here I have to make the distinction between something called primary headaches, which is migraine is the most common, not the most common, but a very common cause, and secondary headaches. So there's actually 210 plus diagnoses in this classification, which justifies why, as a neurologist, I'm never bored. So here we have primary headaches, migraine, tension type headache, trigeminal autonomic cephalgias, and others. And secondary headaches are headaches that are caused by something like an infection, a vascular problem, a trauma, a concussion, a drug, an intoxication, and so on, right? So migraine is not a secondary problem. Migraine is something that comes directly from the pain system in the brain. That's why we call it primary. So the first thing I want to do is separate migraine from tension type headache. This is the one question that the media ask me all the time. And I've shown here this tree, which is the black and white picture in the reverse, to say that migraine and tension type are mostly mutually exclusive in a sense. So migraine usually will be associated with other symptoms like nausea, sensory hypersensitivity. Tension type is mostly a headache, usually both sides of the head, that's mild to moderate, and there's no other symptoms. For some reason, like phonophobia is there, but usually I don't mention phonophobia. So tension type is just a headache, and migraine comes with other symptoms. This is how it has been defined. Of course, humans can have both tension type and migraine because both are extremely common, and many people will make the difference between a tension type and a migraine. And if you have chronic migraine, you might definitely have both. Cluster headache. I want to make a few comments on cluster headache. This is a topic that it's very dear to my heart. I follow a lot of these patients. I saw one today. Cluster headache is different from migraine. It is a diagnosis. I will go actually on the differences. So cluster headache is usually something that is only on one side. Migraine usually will not be only on one side. It's less long, it's shorter. The attacks are shorter than a typical migraine, so usually less than 3 hours. The intensity is usually more severe than a migraine. And then people with cluster will be restless, they will rock, they will move, they will be agitated. People with migraine usually are quiet, they want to stay calm in the dark room. Cluster headache also works by bouts and remission. So sometimes the attacks are there and sometimes there's no attacks at all, as migraine usually goes over and over with a kind of a regular frequency. So I'm not going to go into great depth about this because this is something that even neurologists sometimes struggle with. But just to tell you that migraine and cluster have some things in common, right? But also have a lot of differences. Now, this being said, I want to go now to the Dr. Smith cluster migraine, and I see this diagnosis a lot on social media. So cluster migraine is not an official medical diagnosis. It can mean two things usually when people say they have cluster migraine. It can mean that they have both migraine and cluster headache, so they have both things, but they do differentiate. Or it can mean that they have attacks with traits of both disorders and it's difficult to kind of tear them apart, which is which, right? So this is something we see sometimes. Not everybody is exactly like the international classification says it should be, right? So some people are sitting somewhere in between, and then it's the decision of the patient and the doctor which treatments should be tried. So cluster migraine is not an official diagnosis, but it exists for a reason that sometimes things are not clear. Another thing I see a lot on social media when I read the groups is something like this. So my migraine attacks are very difficult to treat according to my neurosurgeon. And since I had a brain tumor, it's been very difficult. Or, my migraine started after an accident. So this is where it gets a bit complicated because any headache will be head pain. And then either you have the migraine symptoms like nausea and sensitivity to light and sound and so on, either you don't have them. So either you are tension type or either you're migraine type. But the hard truth is that most secondary headaches, tumors, strokes, infections, sinusitis, thrombosis, a headache related to an inflammatory condition, they will come with nausea and phonophobia and photophobia or sensitivity to light or sound. So when the residents that I trained in the old days when I was at the CHUM, I told them stop calling those migraine symptoms because those are symptoms that are also associated with secondary headaches. So the key to a primary headache like migraine is that there's no other cause, and that usually it comes as a recurrent form over years and years. So the other thing is that, of course, if you do have migraine, like 15% of the planet, you are absolutely entitled to also have another headache somewhere in your life. So someone with migraine might have a tumor, might have a stroke, might have a bleed, might have a sinusitis, and then develop a headache that may look like migraine, but maybe be slightly different. So the point here is that if you have a cause to your headaches that's really clear and it's been diagnosed that way, well, it's better not to call it a migraine. It's called it headache caused by or secondary to. But you might have migraine and a secondary headache. So this is interesting because this is the classification of epilepsy. And epilepsy actually made that very clear. So they said, okay, we have different types of seizures. We have the big seizures, like people shake, and they of all limbs, like we see in the movies. And there are seizures that are more subtle, okay, where people just stop, look in the air and so on. So different types of seizures, but then there are different types of causes. So epilepsy as well can be caused by an infection, a stroke, a tumor, and it can also be genetic, just like migraine can be genetic without any other cause than software issues in the brain. So I wanted to show this just to say that in epilepsy, I think the classification reflects a bit better reality than what we're trying to do with this secondary primary headache. All right, so now we thought about how migraine is different from tension headache, cluster, and secondary headaches. Let's go back to Dr. Smith, and I want to say a word about post-traumatic headache because it's super common. So post-traumatic migraines. Post-traumatic headache is not the same as migraine with no history of trauma. And here's a bunch of recent references that just prove the point. So first, they are different on the functional MRI. So we have imaging proof that they are different. They have different symptoms. Of course, some symptoms can be similar because just what I said, any headache will be either like a migraine or like tension type, but they are different in other characteristics. They have a different prognosis. It is more difficult to treat post-traumatic headache than treat pure migraine with no trauma. And if those of you who know about CGRP antibodies like Aimovig, Ajovy, Emgality, and so on, those work very well for migraine. They do not seem to work very well for post-traumatic headache. So it looks like those things are different, right? If you develop migraine as a teen or young adult with no headache trauma or nothing, no head trauma, and you have pure migraine, it's one thing. But if your headache started clearly after a trauma, it's a different thing. The problem is that, of course, it can be more complicated because here you have all the different scenarios that can happen after an accident. So you can have someone that had no headache before, has a headache, and then it gets better. But you can have someone who had no headache before, has a headache, doesn't get better, or you can have someone that had migraine or tension type headache before as a primary headache, then had an accident, and then either the migraine gets worse, or there's a new type of headache that is added to the pre-existing thing. And that is where the insurance companies are so complicated because they will tell you that's always because you had migraines before, right? So there are a lot of different scenarios that require a careful history. And sometimes, just last week, I saw a woman, she's had 5 different head traumas in her life, and all of these contributed to her current state of things. So lots of scenarios. And in our practice, we know that when someone has a history of migraine, there's more risk of developing post-traumatic headache. And sometimes it's just not one trauma. It can be a whiplash 10 years ago. It can be a ski accident 5 years ago. And then it can be another accident just last week. And then you have a mix and match of migraine, tension type, neck pain, post-traumatic headache. This is not an easy situation. And it does require, once again, a careful analysis by a healthcare provider just to try to see which way is the right way to go. Okay, so now I've gone over, what is not migraine. Let's say it is migraine. You've made a diagnosis. It's pretty clear there are attacks and so on. What type of migraine is it, right? Because there's so many different declinations of migraine. Migraine is very diverse. It can come with different triggers, with different patterns, with different symptoms, with different severities, and with different problems like medication overuse, for example. So because migraine is in the end, it's more than just a headache. So we have taught about the criteria, but in addition to the criteria, it's like, you have the basics and then you sprinkle your toppings, a bit like on a pizza, right? So you have basic pizzas, dough with tomato sauce, and then you can put toppings on it. So, I have migraine with, in my case, I have that, like in someone's case, you have diarrhea. Someone else might have vertigo and dizziness, and then we call this vestibular migraine. Someone might have aura, and we'll talk about that. So there's a lot of different things that can be added to just a basic migraine criteria to build a more precise picture of your situation. So if we look at migraine classification over time, well, this has been very fascinating because in the 19th century, when nobody, there was no CT scan, no MRI, no I'm not sure EEG existed then. We had really nothing to look at the brain. And so, well, people classified migraine based on the color of the face of the person. So there were white migraine when you turned pale, and there were red migraines where you were all red, right? So this was an interesting theory based on what people could see. After that, it went to migraine with aura, which we will talk about in a few minutes. And then there were other things by symptom. Vestibular migraine, exploding, imploding was another thing that we talked about. Then there's the world of triggers. And this I see a lot on social media. So for example, I know a lot of people who would love to find a treatment for weather migraine or sinus migraine or neck migraine. So those are popular things. So those are not in the classification because we lump all migraine together. But in practicality, this is what happens, right? This is migraine that's linked to a particular trigger. The one that we put in the classification is menstrual migraine because this has been actually studied and there are particular treatments for it. And then the current way to diagnose migraine is according to frequency, right? So when we go back to the Dr. Smith thing, and I'm gonna go back here. Oh my God, okay, here. You see, so you can see transformed migraine, right? So all of these things, sorry, I'm moving here. Oh, there we are. So if we go back to Dr. Smith here, he put chronic migraine, complex migraine, daily migraine, and transformed migraine. All of this refers to migraine and headache frequency. So migraine is actually a continuum. Some of you might have a lower frequency and others, in some cases, you have no headache-free days, like your life is having a headache to some degree. So migraine is this continuum. And over a lifetime, you might actually go from a better state to a worse state. And maybe, hopefully, you go back to what we call episodic, where you have less frequent attacks. The majority of people on Earth have low frequency episodic migraine. So people who have 1 to 6 or 7 days per month of headache. And that's very good because, of course, the impact is less. It doesn't mean there's no impact. But the majority of people have this. But still, if you put together chronic migraine and high frequency episodic migraine, it is a lot of people. Okay, so here is one of the things I say a lot to the insurance companies. Migraine is invisible on an MRI, right? But very visible on a headache diary. So I've put the headache diary of one of my patients. This is a paper diary where patient just said, 1 is mild, 2 is moderate, 3 is severe. This is kind of a 3-tier, 3-level approach. And you can see this poor person here doesn't have a lot of headache-free days, has a lot of triggers like stress and fatigue, and he's using naproxen and amitriptyline to treat the attacks. So this is actually a diary from another patient I saw recently. This person, this is kind of a bit of a more compact version. And you can see this person has episodic, so it's not chronic. There's not 15 plus days. And if you look carefully, you'll see that P is the beginning of her period. And there's always something linked with her period. So that would be, she also has other attacks, but there's something around the period where she always had a bad cluster. If you look at the bottom in June, there's a P there, and you have this block of attacks. So she has episodic migraine with menstrual migraine. So that's one example of a diary that says the diagnosis. If you'd like to try our Canadian app for migraine monitoring, the Canadian Migraine Tracker, I certainly encourage you to do it, because you can actually record the intensity, what you took, triggers, auras, periods, etc. And all of this is really helpful to help your healthcare provider to guide you and choose the right treatment. So if you haven't tried it, it is way more simple than Migraine Buddy. That's why it was designed. And I hope that you will find it helpful. You can actually send your diary to your doctor by email or even fax. So let's go back to chronic and episodic. Okay, I want to make just one political comment. As Migraine Canada chair, I mean, my goal is to have migraine recognized, treated, and so people have access to therapy. Chronic migraine is actually using chronic migraine just for people who have more than 15 days per month is a very unfortunate use of this term. Why? Because in chronic diseases, you know, monitoring, if you have this kind of tag of being a chronic disease, you get a lot of good stuff. For example, money for monitoring, research, public health programs, therapeutic education for people, disability recognition. So what are chronic diseases? Things you know: diabetes, cancer, chronic lung disease, kidney disease. So migraine in general is a chronic disease. It goes over years and years, starts very young often, and then goes over your life and then has a severe impact on you. It's one of the top causes of disability. So my point is, how should we classify, quantify / diagnose migraine? Personally, I think we should let go of this stupid episodic and chronic dichotomy. There's just like two buckets. We know it's not true. We know it's way more complicated than that. And we know we can quantify migraine with a headache diary. And we know the frequency will actually go up and down, right? Depending on people. So usually the way that I diagnose, I treat my patient is I look at what they are now. And I say, well, you know, are you at 4 to 6 per month? Are you at 20 plus per month? Are you at 12, 15 per month, right? Because to me, as a physician, it's way more useful to have exact statement of facts instead of just episodic or chronic. So in my perfect world, we would just take migraine as a chronic disease, and then we would have an exact quantification of what the current state of things is. Okay, so let's move now to migraine associated with other pains, right? A lot, and Dr. Smith actually did not put that there, but I'm talking about the neck migraine, the sinus migraine, and TMJ pain. So this is something called the trigeminal cervical system. Sorry, my cat is getting dangerously close here. Hello, hello. Oh, she leaves. She's getting close to my keyboard. Okay, so the trigeminal cervical system is something that we have as human beings. And it is actually a link between the nerves of the face and the nerves of the back of the head and the neck, right? And all those nerves just kind of have connections together, leading to a link between the back of the head and the front, and the jaw, and the ear, and the sinuses. All this is one pain system, right? So here you can see that the different pains, I'm sure some of you have had pains like this. So this leads to a lot of problems in diagnosis, because quite a bit, right? People are falsely diagnosed with something like sinus headaches. There's been a study in Mayo Clinic showing that sinus headaches 80% of the time are actually misdiagnosed migraines or migraine that has symptoms in the sinuses or triggers in the sinuses, right? So we have to understand that this is kind of a two-way road between our painful parts like the eyes, the TMJ, the neck, and the sinuses, and the migrainous brain. So sometimes it's very difficult to differentiate between your triggers and your symptoms. And sometimes both can be true. So I'll give you an example. Patient of mine has allergies. So every season of allergies triggers tons of migraine because then the sinuses are all irritated and then this triggers attacks. But sometimes this person may have a migraine that causes pain in the sinuses. So every time that you think about pain somewhere and a migrainous brain, you can think kind of a ping pong game, both sides. So this is true for the sinuses. This is true for TMJ. 80% of people with chronic migraine, frequent migraine, have TMJ pain. This is something that is seen very often. And then the cervicogenic headache, I'll make a bit more comment about that. So when you think about the brain with migraine that has this particular chemistry and electrophysiology that I mentioned, well, it is sensitive to the environment. And then you have to see this as really as a ping pong between the brain and the environment. So migraine is frequently mistaken for sinus headaches for the reasons that I just told you. So migraine can be triggered by different things like weather changes. Tearing and nasal congestion are common during migraine attacks. Sinus medication can help migraine sometimes, so people think it's a sinus problem. So the sinus I spoke about, but I want to say a few words about cervicogenic headache. This is something that is very controversial, even for us doctors. I'm just back from a conference and I had heated debates with my colleagues about what is cervicogenic headache and what should we do about it, right? Because as I've shown you, the neck and the head are one and only pain system. It's the same pain system. So sometimes it is very common for people with migraine to have neck pain. And it is very common for people who have neck issues to trigger headaches. So once again, you have this kind of two-way road. And more complicated, in the neck is a very complex structure, right? It has muscles, bones, facets, nerves, and then all of this just talks to the pain matrix, to the brain. So it's not easy to make sense or rhyme or reason of this. And usually it's actually best to just look at the whole picture and try to figure out treatments that could be helpful. Okay, last part with Dr. Smith. So Dr. Smith treats also aura migraines, hemiplegic migraines, silent migraines, and 2-time silent migraines. I'm not too sure why it's there twice. So what is an aura, right? Some of you might have it. The aura is something that's been described since quite a bit of time. This is one of the first description in the 1870s. It is usually a visual symptom. So, and here I've shown you here some drawings made in Brazil by people who had auras. And you can see how diverse and how even artistic those auras are. They can be in color, they can be in black and white, they can be little dots, flashes, they can be one side, they can be both sides, they can be progressive usually. And so the vast majority of auras are visual. This being said, this is a study from Scandinavia in 1996. Some people who have auras, I saw one today in my office, have visual symptoms, but some have also sensory stuff, tingling, numbness on one side of the body. And some of them have speech difficulties. So what is the cause of the aura? Well, the cause of the aura, and here you see a guy from Brazil. This is Dr. Leao. So this guy was studying epilepsy. So he was looking at abnormal electrical activity of the brain. And he was hoping to find some epilepsy stuff on the rabbit brain. But what he found was a different type of electric abnormalities he called cortical spreading depression, because he saw on the brain, it was kind of a wave of what we call in neurology depolarization. So it's like the neurons fire and then they stay very quiet, right? And this is thought to be the cause of the aura. So this wave goes on the brain. Depending where it goes, it causes symptoms, usually visual. There's been a lot of other research made on this with fMRI, and then also other experiments just showing that cortical spreading depression can trigger a migraine. I don't want to go too deep in there. I know it's a bit of advanced science, but just to tell you that the aura, we know where it comes from when it's typical, and it's different from just a migraine attack where, you know, it's usually an inflammation with peptides released in the brain and so on. So when we see a migraine aura, the aura is one thing and migraine is another, the headache phase, and they are related. The other problem we have is that there's a lot of other symptoms that come with a migraine attack, and it's not clear if they are typical, right? So a lot of disorientation, brain fog, weird tastes, somatic sensation, tightness of the neck, dizziness, vertigo, vestibular migraine. For all of this, it is not clear at all if these symptoms are caused by cortical spreading depression. So it's not clear if we should call these aura. So usually we keep aura for a set of symptoms that ideally a neurologist will clarify with you. It doesn't mean that those symptoms do not exist. It just means that we don't know yet where they come from. And here is the usual way that a migraine attack will evolve over time. And interestingly, there's something a bit weird here, is that I know a lot of patients who have premonitory symptoms like prodrome, and I know a lot of patients who have auras, but a lot of patients have no prodrome and no aura. So I think the point I want to make here is that everybody's different. And some people might have a prodrome or a postdrome or none of these. Some people might have aura. Some people might have symptoms that we do not yet understand. So I want to go now to this term, silent migraine. I've seen it a lot on the social media, and actually even contacted the American Headache Society, so they remove it from their communications, because silent migraine first is not an accepted diagnostic term. Why do people use this word? Because there's always a reason. I mean, usually when we use words, it's because they describe something that exists. So this is usually used either to talk about the phase without headache, prodrome or postdrome, right? So this should be called prodrome and postdrome, not silent migraine. The other thing is sometimes it's called to describe an aura without headache. So this is an aura without headache, so not silent migraine. And then sometimes we use silent migraine to describe any other symptom, usually dizziness, that is not explained by, that is not associated with migraine diagnosed, right? And that it's, that we don't know exactly where it comes from. So now that we understand migraine better, the natural thing to do is say, well, you know, maybe this could be caused by the migraine chemistry and electrophysiology, and we just don't know it yet, and there's no headache phase, so we'll call it silent migraine. Remember that all we know about migraine has been found in people who had the typical headache according to criteria. So if there are other symptoms that are completely separate from migraine, I think we should be very careful about calling them migraine. I know this might be a bit shocking to some of you, but I just want to be wary of using the right words so we actually can do good science and develop proper treatments. A last word on migraine and triggers. So migraine and triggers, there's a lot of this I see as well on discussions. My patients talk to me about this all the time. You know, can I adapt my treatment to my triggers? So if I have menstrual migraine, weather migraine, emotion migraine, food migraine, neck migraine, sinus migraine. So obviously, if you think about this kind of brain and periphery thing, sometimes there are triggers that you can manage, right? You can take different types of contraception for menstrual migraine. You can manage your food, your diet. You can adapt your exercise. You cannot do a lot about the weather, sadly. And then usually improving prevention is best, right? So you actually increase the threshold of your brain to the triggers instead of just controlling the triggers. And so far in our practice, it is still trial and error. There is no predictor saying that this drug is going to work better for any trigger. Apart from menstrual, there's a bit of an exception there. But the other triggers usually will just use our treatments that we have. And we're lucky because there's actually a ton of different treatments. And I invite you to look at our webinars, our podcasts, our PDFs. There's a lot of options to treat migraine these days, right? So basics are just kind of lifestyle, then all the natural and alternative world, then the acute meds, the preventive meds, and now we have things that do both. So it's even cooler, neuromodulation devices, CGRP antibodies, Botox, G-PANs, and then things that are controversial like cannabinoids and things we should not be using like opioids. So this is a bit of a map of what people usually try. And whatever the diagnosis is, right? And so for those of you who have maybe a tumor, maybe you had a stroke, maybe you have other diseases than migraine, you have a secondary headache, or you have a mix of different things, or maybe your doctor doesn't know what you have because it's a big, complex thing. Well, very often we will use migraine treatments anyway, because, you know, migraine treatments act on this chemistry of the brain, on the electricity of the brain. We have evidence for them, we have data for them, so why not use them? The most typical example is post-traumatic headache. Usually what we do is if it looks like migraine, we treat it like migraine, right? But we do need more research to treat secondary disorders and secondary headache. So because we don't have something specific that's developed for those headaches, we use migraine therapies, but it doesn't mean that it should remain that way. So in conclusions, I want to encourage you to use precise terms as much as possible, right? Clarify your diagnosis with your healthcare provider. Usually the key is in the history of what happened, your symptoms, what you've tried. You can have many diagnoses. A lot of my patients have 2, 3, 4, 5 different diagnoses, and then we tackle them one after the other. There are still gray and blurry zones. I mean, there are patients, I saw one today, I'm not even sure what the diagnosis is, and I'm just trying things to help my patient based on her symptoms, and her symptoms are right in between neck problems, nerve problems, and a migraine problem. So, you know, even in the best of hands, there might be some uncertainty, and then try available treatments with the guidance of a healthcare provider, looking at your symptoms and finding your way. So I want to thank you for your attention. I'll take questions, but before that, I would like to share with you that this is our first ever fundraiser for Migraine Canada. It's Move for Migraine Canada, so you can still sign up, and as a team or as an individual. I did it. It took me like virtually 10 minutes to do it. And you can do anything. You can do a little stretching session. You can walk around your block. If you're an athlete, you can do more. And whatever you want to do, the key is to raise awareness, right? So sign up, talk to your networks, talk about it, and then maybe you can even raise a bit of money. I think we're already over our goal, but more money is more projects for people with headaches. I want also to call you and invite you to join our community by joining us, by supporting us, watching our webinars, looking at our advocacy page, looking at our library, where there's a lot of PDFs that can actually help you, listen to our podcasts, and write to us if you have suggestions, questions, or if you'd like to volunteer. So on that, I'll close and take questions.